Hi guys, long video coming up this time for a delightful patient called Mike. Quite a long vid because I want to talk through some of the history of this verrucae. I'll do a little bit on the anaesthesia. And then he was one of those guys that had a post-procedure bleed. So I've left that in just to show you guys, particularly fellow pods, what can happen after a full thickness excision.
Right, so we're going to do probably, I think, two videos. First one, I think, will be just chatting about this lesion, doing a bit of a background. So I think it has grown a little bit. So we've got this one here. I think you're getting a little friend just here.
Yeah.
So first thing we're going to do is clean your foot and get you numb. Now, I actually did a little video, when was it? Last week, I think, where I did a... What did I do? I think verrucae excision, and it was up here. Now there's two ways we can do this. We can actually inject through the top on top of it, which I will do anyway, because then it floods the area. But I'll actually put a bit of a tibial block in here. Sorry, I'm being technical.
That's fine.
So I'll do a block here and here on the ankle to make you kind of nice and numb. So just in terms of the history of this lesion, sir, how long's it been there?
From almost teenage, beginning of teenage.
So that's what, 20?
38 now.
So 20 years. 20 years.
25 years.
And in terms of other treatment, you've had
I've done home treatment with bazooka.
bazooka, that
cryo
Yeah.
from GPs.
Yeah.
Multiple doctors have cryoed it. I've
Yeah.
had heavy acid ablation treatment, and I've had microwave.
Whoops, daisy. So I'm just going to zoom in on that. Right, okay, viewers, I'm just going to put that chair down a bit. So it is a belter, isn't it? I'm just going to come back out a little bit. It's a belter. So, what I'm going to do with this, so we talked about needling and cutting it out. Effectively, we're going to cut it out today. It's my sort of upper size for cutting out. Basically, the bigger the cut, full thickness excision, the bigger the wound just take a little while to heal in. Had it not been around for so long, I would probably have wanted to try needling because that's my kind of preference to try and build up an immunity. But I think with this one being particularly stubborn, I think we kind of cut it out. Downsides are, as we talked about last time, about a 10% chance of recurrence, about a 10% chance of painful, crappy scar, but a good chance would be a lot better.
Yeah.
Right.
If it does reoccur or get the bad scar, is there anything beyond
Yeah,
that?
so after that, the next thing I do is actually I do an excision with a flap. So I take the lesion out, take some skin from here and do a plastic surgery flap, which is technically more difficult. You run the risk of a secondary scar and a flap defect, but for the bigger lesions, that's what I do.
Yeah.
If I've got two bigger lesions, if I've got something that's about yay size, I'll come back. So if I've got something that's about that size, then that's really kind of too big to excise as one. So what I'm going to do now, sorry it's looking like one of those dodgy Japanese videos where the camera's moving around. Not that I've ever seen those dodgy Japanese videos, but I am aware that they exist.
I didn't bring the Godzilla mask.
So what we'll do, we're going to clean the foot and get you numb. So why actually video that as well? Let's just stop that bit for a sec.
Photography and things.
Well, you just want the videos to look really good. So let's just do that anaesthetic then, sir. So first thing we're going to do is just palpate that pulse, which is, should be able to see it on a skinny fella like yourself, really. Okay. So there she blows. So we're going to follow the pulse down. So this is your artery, sir. Now that's our landmark. We'll avoid that. And the nerve sits just behind it. So we kind of go in a little bit underneath. My finger's in the way. That's a great job of trying to video. So that is going to be, so that is our tibial nerve. And that supplies all of the underside of the foot. Now the trouble with the top of the toes is, some of the nerves from the top nerve come through the toes, so you get a little bit of a crossover. So this is the main nerve we need to block, but we'll put a little one in the top as well. So prep that skin. So we've obviously been through this gentleman's medical history first. Just do a little bit of skin prep. Get this going. And this, of course, is deciding not to work today. Might have to edit that one out for the camera. What are the chances of this not working? significant. Well, that's a little bit dry,
Yeah.
but never mind, so is my sense of humour. That one is going in the bin. Think of a word. I should really edit this out, but I really like to leave those in so that people can see. So the video, my kind of channel is basically for fellow pods. We use a different one. We want to hear a click. There you go. And so when I kind of have videos that show life not going quite exactly to plan, I actually leave those in because they're quite amusing and it's a bit more real life really. So,
Nothing ever goes to plan.
well, no plan survives contact with the enemy. Who said that? General von Moltke. He was a Prussian soldier. General.
Yeah.
So you have a plan, but you must always have a plan B. So we've mixed up some Narrapin. We'll get some of the air bubbles out. Okay, so just trying to watch my fat hands in the way. Right, so little scratch. 3, 2, 1, scratch. Okay, we're going to just come in just behind the artery. Look for any flashback. Oh, there's a little bit of flashback in the needle, guys. That's good to see. Okay, so that shows you just how close we are to the artery. Now we're actually going to not use that syringe because we always have a spare. Good to see. So that means we're very close to the tube. That actually is not what you want, but it's what you want to avoid. So I talk a lot about different types of syringes. So in the UK, they particularly like dental syringes. You can't aspirate them very well. That's why I don't like dental syringes. Now you know that we are in an artery. Not a good look. Okay. So we're going to come a little bit further behind. 3, 2, 1, scratch. Sorry, fella. We don't charge that extra scratch. So I'm going to come a little bit behind. Aspirate again. Okay. Now, might be a bit stingy. So we're just going to re-prep the skin. So we're going to use our little ChloraPreps again. Look for the click. There we go. So.
First time, this one.
Yeah, the other one, that was just so amusing. So now I'd said we'll put a little bit of local infiltration in. So what I'm going to use for that is just a little bit of local anaesthetic, just to kind of cut down some of the bleeding effectively. Now I will actually use this technique, Michael, just on its own, but I wanted to kind of show some other things. Did that scratch?
Yeah.
Did it scratch? Oh,
Yeah,
interesting. Okay. So a little bit of nervy on the top. Sorry about that, fella. Well, so I thought I'd blocked superficial perineal nerve viewer, so obviously there's still a little bit of feeling on the top. Okay, so that's just a little bit of adrenaline in there. So let me say, so sharp on the top.
Feel that, yeah.
Okay, I thought I'd knocked out the superficial
I
perineal
can
nerve.
feel it where you touched this that last time. That I can feel.
Okay, sharp there,
Cold, not sharp.
sharp there.
No.
Okay, so now interestingly, so I put a little block on the top,
Yeah.
so I've taken out the medial branch of the superficial perineum and not the lateral. Oh, this is a really good video for how to do things. I do know what I'm doing, viewers, I promise. But this is why we check. So
Yeah.
so I am just going to check. So no sharpness at the top end of the lesion there.
Can't even feel you touching that.
So all the tibial nerve had absolutely gone off. Medial branch of the superficial perineal, but not the lateral. Normally you find some of those fibres from the top come through. Didn't need to for you. Okay. So we just test again. Nothing there at all. All right. So.
All right, if I do feel something, I'll shout.
Well, don't shout. The best way to get hold of me, Michael, is email. Or you can ring my
What's the
secretary.
waiting list for that?
Oh no, well, I look at my emails twice a day. So what I'm looking to
Just
do,
like a broken clock.
yeah, is write twice a day. So there's still a little bit of bleeding there. So on a good day, today's not a good day, that local anaesthetic with adrenaline will really close that circulation down. I know my fat hands are in the way. Sorry, viewers.
It's alright, just a bleeder.
Well, that's what it says on your notes. This bleeding patient. Okay, so this is where you need your very own version of Debbie McGee, as in a glamorous assistant.
Distract me from what you're doing.
Yeah. So there's the lesion. So quite a thick thing, as you can see. They're really quite a chunky lesion, and a little bit of claret. There's a tiny little one there. So do you know what? We'll get that out as well, because why wouldn't we? And then we will follow him up. Now, first bandage is on for a week.
Yeah.
And then it takes about, really, I think about 3 weeks for this to heal in by what we call secondary intention, Mike.
Yeah.
A little bit of claret getting away from me, come back. Okay, and that's it done. So once we get going, it's really quite quick. And then what we do now is we pretend we're like the little Dutch boy in the dike, and we put our finger in there for a wee while. So,
How big was it? I mean,
I'll show you. So, the last bit of anaesthetic I put in actually had a bit of adrenaline in. That should really have closed the circulation down.
Yeah.
But the one we put in the ankle really opens the circulation up. So that's why it's bleeding a little bit.
Yeah.
But that's okay. The good news is, and this is a medical fact, everybody stops bleeding eventually.
Like the last time they bleed.
Well, yes, indeed. I mean, yes. It's a bit like, you know, you don't need a parachute to go parachuting, Mike. You need a parachute to go parachuting twice.
Yeah.
So, and then a little bit of a bandage. Do you know what bandage is French for?
Bandage.
Bandage, correct. Oh, you're doing me jokes. It's trouble when
Lived in
you.
Montreal for a while.
It's a problem when you have an actual intelligent patient. Mike's a scientist by background, so he's probably got O levels and everything.
PhD.
PhD.
Yeah.
Oh, now that's what I go. Okay.
Sadly, you're not the only doctor in the room.
Sorry, Dr. Mike. Well, I'm not actually a doctor until next month.
Oh.
So I'm basically a jumped up chiropodist who thinks he's a surgeon. But I've been doing my doctorate over the last 4 years, and I've got my Viva defence in 3 weeks' time.
That's good. Good luck.
Well, yeah. My buddy who went through it just before me, it's 3 hours, proper grilling, but it needs to be, you know.
Same as mine, but mine was chemistry rather than physics.
Okay. Mine's on injection therapy, which is my particular thing. Now, we're going to put that on, get away, we're going to put that on, just watch for a little bit of claret, because it was a little bit bleedy, that one. So, just move the camera, that's fine. So we're just going to check that we don't get any claret through there. Question, sir, what can I tell you?
All gone?
Oh, it's all out now.
Brilliant.
Painkillers, dressing, and then we'll see you next week. Thanks. So, what were we saying about no plan survives contact with the enemy? So Mike has had a bit of a bleed. Now, I was in 2 minds whether to kind of do this next bit of video. Hey, Sharon. Thanks, Chuck. So we need a new post-op shoe, don't we? They come in 2 sizes of shoes, Mike, all right? 2 big and 2 small. So we're going to have to use a bit of a bigger dressing. So that's okay. That's okay. You're still nice and numb, aren't you?
Yep.
So get all the bits ready. So what we always do with these curatages, and I'll probably put a little bit on the video when I edit, is we get the vasodilation or dilatation from the local anaesthetic, and we had quite a bit because we did a nice tibial block for Mike, and such that when we put the adrenaline in the toe, it didn't actually do anything. So normally a bit of pressure does it, but Mike's decided that he's going to make a mess of my shoe. Now, let's get this
It's a
off.
challenge.
Not in a bad way though, sir. Not in a bad way. So let's this one's going in the bin. You just lift up for me, sir. Alrighty.
Okay,
A
that's
little bit of cloth. Sharon, if we get rid of that, and so we've had a little bit there, Mike. I mean, it's not awful, but I can't in good conscience send you home like that over the weekend. So let's change that dressing. Not the first one I've had. It happens. But that's why we keep a little eye on you before we let you go.
Yeah.
I mean, I can tell you I've cut myself worse shaving. That was quite a cut.
Why do you think I have a beard?
Oh yeah. Alright, so that's it there. So we'll get that out of the way, and I mean I had one case where actually there was a little artery that was pranged and I just had to put a stitch in.
Yeah.
So that's really, it's just vascular bleeding really. But currently verruca free. So we'll get that out there. Thank you very much, Sharon. Reminds me, got black pudding for tea tonight.
Nice.
Right. So Sharon, can I get another non-stick? So an Inidine or a Gelinet or something like that. And then basically what I do now is I put my finger there for about 2.5 hours, and
Okay.
that's it. So how's your small talk? We were talking about ionic and covalent bonding a minute ago.
Is that your idea of small talk?
Well, I don't get out much. Sharon, have you got a finger on there for me?
You
Now,
know, the good old joke about why are bears like bonds?
bombs?
Bonds.
Bonds? Go on.
Some of them are polar.
Oh, now I like a chemistry joke.
I'm sorry, YouTube.
That's
viewers.
very good. Very good. Oh, I'm going to have to come back with some chemistry jokes now. Put me on the spot there now. All right, put in there. In fact, Sharon, put your finger there. Now, Sharon, you can't take your finger off. Now, Sharon, I'm going for a cup of tea. It's going to be about 10 minutes.
What's that? You got an emergency call back at home?
Yeah, I've got to go. Yeah. Right, okay, let's get a bit more bandage on that. Okay, Chucky, thank you very much. I have it. Marvellous. Right, so Mike, what I'm going to do, actually, I'm going to straighten your leg out.
Yeah.
Sharon, we've just lost our video. Can you just pull that trolley back? Just pull the whole trolley back. Awesome. And where are we? We are wrong. There you go. Okay, let's actually get a bit of pressure on that. So my first ever chemistry joke, when I was doing my A-level chemistry, Mike, was we had a chemistry teacher called Dr. Ashford, and he was brilliant when we were doing our A-level chemistry. So in between Mike having a dressing and bleeding all over the floor, we were talking about ionic and covalent bonding. So this was the guy that taught me all about ionic and covalent bonding, and he used to have this nice thing. He used to have a little rhyme, and it was poor old Dr. Ashford, alas he is no more, for what he thought was H2O was H2SO4. You know that one, obviously. But you know, that was our first ever chemistry joke, and he had lots of little ones like that. And he taught us all about, you know, molarity, which never made any sense to us, because it was like, well, how is one mole different to another mole? But he couldn't get over the concept of a mole being a different amount based on different compounds. But you're more inorganic chemistry, you say?
Physical chemistry.
Physical chemistry. Yeah, see, organic chemistry is the one that interests me, being biochemistry type. Shall we take some Coban, I think? Are we still in shot? Yeah, kind of. So basically, just a bit of bleeding. Not a lot of bleeding, but just enough you want to basically just go on the flow.
Yeah.
Still nice and on there, Mike?
Yeah.
Cool.
Starting to go more pins and needly
Mm-hmm.
than completely dead, but
So, yeah, I think I will add that last little video in just to kind of show, and as I was chatting to you today, is these vids, although, you know, anybody from around the world looks at these vids, they're really aimed at fellow pods. And, you know, it's about saying, you get some bleeding, it happens, you just kind of manage it really.
yeah.
I'm not sure I'd pick up any work from my YouTube videos, because if patients see patients going, ow, and then bleeding all over the floor, they probably say, well, I'm going to avoid that guy, which is fine.
You get the job done, it doesn't matter.
Well, standards. Right. Video off, and let's see how you do. Cheers, mate.
Right.
So this is Michael at 1 week, and we're taking the dressing down. Interestingly, there'd been no further bleeding despite the significant immediate post-op bleed. After that completely stopped. Here we are now with the dressing off, and you can see it's already about 50-75% granulated in. Had very little pain, as you'll hear. And what I normally do with these is dressing at 1 week and a dressing at 3 weeks. It's normally fully healed between about week 2 and a week 3, and then we do a 3-month follow-up just to see if it's finally gone after all these years. So I'll do another follow-up video in the new year when I see him back.